Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series focuses on demystifying the Medical Council standards. So welcome to this podcast on Medical Council statements on cosmetic procedures. My name is Chow Yen Chen and I am a medico-legal consultant at Medical Protection Society and an anaesthetist for Te Whatu Ora. I'm very lucky to have today with me Dr. Tim Cookson, fellow MLC and GP.
Hi, Chow Yen.
Hello, Tim. We're also fortunate to be joined by Adam Holloway, who is one of the partners at our panel law firm, Wharton Carney.
Hi, Chow Yen. Lovely to be here.
So this statement is very prescriptive, and so I thought I would start by going through the definition Council uses for what a cosmetic procedure is. So they're operations and other procedures that revise or change the appearance, colour, texture, structure or position of normal bodily features with the sole intention of improving the patient's appearance or self-esteem. So Medical Council goes into a lot of detail in this statement about its expectations. If there is a complaint, the care will therefore be measured against what's set out in the statement. And this is because there are potential for conflicts, as providing cosmetic procedure does not improve a patient's physical health or does not necessarily improve a patient's physical health, and it may be difficult to determine whether the procedure is therefore in the patient's best interests. So Adam, would you be able to go through for us these expectations set out by Council?
Yes, a big part of the statement is dealing with the issue of conflict of interest. So at a high level, the statement talks, and we'll come on to this, about the sorts of accreditation or training the Council might expect you to have. But before dealing with that, it talks about the issue of consent or conflicts of interest, I guess, and then how that feeds into the importance of the consent process for cosmetic procedures. What it alerts doctors to in relation to this potential for conflicts is this. It talks about how you must take great care to ensure that patients who wish to undergo a cosmetic procedure receive the appropriate information, make an informed choice, and give their consent being free from exploitation. And that might have a relationship with, for example, if you're seeing a patient together with their partner. It also talks about the clinical relationship between a doctor performing a cosmetic procedure and a patient, and how that can be complicated by the consumer's heightened expectations of the results that can be achieved and the provider's opportunities for commercial advantage. It says you must recognise these conflicts and have a duty not to allow them to cloud your professional judgment. And pausing there, it's certainly the case that cosmetic procedures can be a real hotbed for complaints because people come into them with expectations of a positive outcome rather than just getting care for something they need stitches or they've got an affliction that requires treatment. So 2 more on the potential for conflicts. The statement provides that you should not abuse your patient's trust. The investigations or procedures you provide or arrange must be made on the assessment you and the patient make of their needs and priorities, and on your clinical judgment about the likely effectiveness of intervention. And finally, do not make a patient feel ashamed or self-conscious because of their physical appearance. Your first concern must always be the patient, and that they may require advising him or her that the requested intervention is not appropriate. And we'll come on to this also, but in one of the examples we discuss, an interaction with a patient was recorded without the doctor's knowledge, and that's something that happens more and more frequently. So you really do need to be careful that you're not encouraging people into procedures that might not be right for them.
Yeah, that's right. And going along with the whole dealing with this conflict of interest, I was talking earlier with Tim about who can do cosmetic procedures, and council also sets out very clear expectations around this. So I get you, Tim, to go through with us the different types of cosmetic procedures there are and what council says about who can or cannot do them.
Certainly. Just coming back to what you were saying, Adam, about and particularly about expectations in relation to cosmetic surgery, that patients have a high expectation of a very positive outcome. The flip side of that, of course, is patients who have unrealistic expectations of what's going to occur. And clearly people who are doing cosmetic procedures are very aware of that, and also of the body dysmorphism type person who comes in who is likely to never be satisfied by whatever they have done. So look, there are two categories of procedures that the Medical Council outlines. And the basic difference between them is that a category 1 involves cutting beneath the skin, whereas a category 2 is predominantly on the surface of the skin, although there may be some things that breach the surface, such as an injection. But basically, category 1 is the one where bits are taken out or added. And this would include things like breast augmentation or breast reduction, rhinoplasty, surgical facelifts, liposuction, otoplasty, etc., etc. These are most commonly day procedures, and we'll usually have someone like Chow Yen present to make sure that all the pain issues are sorted. And they need to be performed by a doctor registered in a relevant surgical scope of practice, who's had the training and expertise, and whose competence in the procedure has been independently accredited. So dermatologists can also do these procedures, provided they've had the necessary training and expertise. And for tumescent liposuction, provided a doctor has met the requirements of the Council's policy for doctors registered in a general scope and meeting certain requirements, or a vocational scope of general practice who wish to perform tumescent liposuction. So again, you need specific accreditation to do these procedures. You can only do these procedures if you're not already accredited, if you're actually enrolled in a relevant training program. So we've had to assist members with complaints that they're not suitably qualified to perform cosmetic procedures, and sometimes these complaints can come from fellow doctors. Adam, have you got any thoughts about the process that Council follows to look into these notifications or complaints?
Yeah, complaints can come from fellow doctors if someone's aware that there's a colleague doing procedures and there's a concern about their training or competence. This is a guess, but I imagine the more common pathway is that someone who's dissatisfied with a procedure will complain to the Health and Disability Commissioner. And then the Commissioner, as part of looking into that complaint, may identify there's an issue around training and refer that also to the Council. So the doctor will find themselves dealing with both of those regulatory bodies at once. This standard, it is prescriptive. It's quite and reasonably clear about what's required. So if you come to the Council's attention and you have been doing a procedure where you don't have the necessary qualifications or training that are prescribed by the statement, you will be called to account for that. The normal pathway would apply, so you'd be notified that the complaints come in, you have an opportunity to respond. It should be quite clear from the beginning whether or not you're in trouble for not having the right qualifications. The response, if you don't, would be to stop those procedures and come to the Council both with an assurance that perhaps notwithstanding you haven't had the right qualifications, you have been proceeding safely and carefully, and a plan around what you intend to do to remedy the situation. At the extreme end, you could be sent on for discipline, but if you're, and this is an example of a case we've had, a GP who's vocationally registered but not accredited specifically for mole removal by the college and has gone ahead and removed a mole just for cosmetic purposes, you could expect to be told off for that, but probably not sent off to the health practitioner's disciplinary tribunal. It just wouldn't reach that sort of threshold. But if you keep doing it, then you may well find yourself in deeper and hotter water.
And the mole issue is an interesting one too, isn't it? Because there's an argument that any mole could be potentially suspicious, even if under the dermatoscope it looks absolutely fine. And therefore, are you removing a mole purely for cosmetic reasons, or are you removing a mole because the patient's concerned that it might become something nasty? And so it may well be that how you word your notes and interpret your patient's request might make a difference. Not that I'm suggesting that doctors who don't have the qualifications or skills to remove moles should be doing it, but it's a little more of a grey area compared with, say, a breast augmentation, which is clearly a cosmetic procedure, and there's no physical reason why that would be needed.
Yeah, that's right. And for example, covering over a tattoo or something that they had got in the past that they didn't want anymore. So not as straightforward as, you're right, a simple mole removal. Yeah, which can cause concern.
No, Jane, you're asking about the categories, and so category 2 is it basically a non-surgical procedure, and this is things such as non-surgical cosmetic varicose vein treatment, laser skin treatments, use of CO2 lasers to cut the skin, mole removal for purposes of appearance, so that one obviously does involve a bit of skin being removed, laser hair removal, chemical peels, and hair replacement therapy, amongst other things. Again, these are most commonly performed as day procedures, but may or may not need an anaesthetist present. To do these procedures, you need to be a doctor with a vocational scope of general practice whose competence in the procedure has been accredited by the Royal College of General Practitioners, or a doctor with a vocational scope of dermatology, or a doctor with a relevant surgical vocational scope. And you also need to have had the necessary training, expertise and experience in the procedure being performed. So if you haven't been accredited, you can still do these procedures, provided you're in a training program and that your activities are being appropriately monitored by a suitably qualified colleague.
Yeah, that's right. So that last part that you talked about being suitably supervised, we get a lot of questions and calls here at MPS from doctors who are suitably qualified, but then they're being asked by nurses or other clinicians to supervise their practice in beauty therapy, in, for example, providing injections, fillers, or Botox, for example, is a common one. What would you say to them if they were considering supervising someone for this?
Yeah, we've certainly had queries along that line. My personal feeling is that you want to be really careful, because the difficulty is that, yes, if there is a complaint, something goes wrong, then as a supervisor, you're going to be held to have a degree of responsibility for what goes on, even though you weren't the person who actually did the procedure. And so if you're saying, yes, I will supervise a nurse to do this, you need to be absolutely sure that the nurse has got the right qualifications and experience and all those other things that we've talked about in general. And you also need to be monitoring their work to make sure that their standards are continuing to be, what is expected. And so that requires quite a lot of fairly close supervision to be able to adequately show to an authority such as the HDC or the Medical Council that you're actually fulfilling your responsibilities as a supervisor of that person. And so, if a nurse in another centre rings you and says, can you supervise my work? I've got all the training, et cetera, you might think, maybe not, because I actually can't see the results. Whereas if they're working next door to you, then that could be very different, so a safer scenario. But I would still recommend a lot of caution.
Yes, fair enough.
I agree, Tim. I think you would need to be careful, and having that physical proximity would assist, so you can both observe the person doing some procedures, be comfortable not only that they have the paperwork to be qualified, but that you also have some experience of having observed and made sure that you're personally comfortable with how things are going. But there's also a systems element that you'll be held potentially responsible for. So you would want to know in advance that the follow-up care is being provided appropriately, that the consenting frameworks are properly in place, that there are plans for, if we're talking about Botox, someone has an anaphylactic reaction, is the right sort of medical care available to deal with that situation. So I think perhaps we're sounding overly cautious, but if you are named as the medical practitioner supervising this sort of thing and something goes catastrophically wrong, undoubtedly the nature of your supervision will come under some sort of scrutiny. That's my view.
Yeah, absolutely. Definitely, I think a lot of members are being asked if they will supervise, and so there's a lot to think about before you say yes, I think.
And consent, which we're coming on to soon, is a particular issue here, isn't it? Because consent, as we know, it's not a signing of a form. It's a process of discussion and opportunities to ask questions and have answers, etc. And so, how do you, as a remote practitioner, ensure that the nurse, who may be totally competent in the physical aspects of doing the work, but how do you assure yourself that their process of obtaining consent is up to standard? And if you're not in the room listening to it, then, it makes it pretty tricky.
Yeah, that's right, because Medical Council, because of the conflict of interest and the risk of favouring your commercial interest over what's in the patient's best interest, they're very, very strict on consent. And they talk about that when you go to obtain consent, that there's some requirements that you provide them all the information that they might have, you give them your qualifications, that you make it a very clear two-way communication, you give them written material, you give them time to consider what you've talked about in the procedure, and they've put down, give at least 7 days before your procedure for a Category 1 type procedure. And then they also have listed some characteristics of a patient where you need to take care before proceeding, and they're patients that, for example, a patient experiencing a current episode of mental illness who has a long-standing persistent body dysmorphic or personality disorder, patient who's had multiple cosmetic procedures and is dissatisfied each time, a patient who appears indecisive or who believes a cosmetic procedure is the solution to all their problems, or a patient who has not carefully and thoroughly considered the implications of undergoing the procedure. And some of them are quite hard to to be certain about. And counsel goes on to say that there must be an opportunity for the patient to be referred for psychological evaluation if you're concerned about their motivation. They say that the psychological support doesn't necessarily have to be on site, but you need to know how to access it for this patient in front of you if you've got concerns. And like we were talking about before, a patient's partner has secretly filmed a consultation before and then made a complaint to the HTC because they believed their partner had psychological problems that weren't thoroughly investigated by this clinician before they offered them and then proceeded to do the procedure, a Category 1 procedure.
Yeah, it's interesting. This statement, in a way, is really just describing best practice consent.
That's right.
And yes, it points out a few things you need to be particularly tuned into or conscious of, like the possibility that the patient's presentation is involved with a mental health issue, etc., like you've just gone through, Chow Yen. But really, what it's saying is that consent for a cosmetic procedure, and particularly a Category 1 procedure, of course, because of its greater significance, has to be best practice. And in a way, perhaps one of the good things about this space is that we're talking about procedures that will be entirely or virtually all entirely private. And so you probably have more control to build a system where you can meet that standard of best practice. You're not running a clinic together with a registrar where you have one brief patient contact before you then see them pre-op and are jostling with the anaesthetist for time to do consenting. You can really get it right, which means treating consent as a process, not as an event. It's not the event of getting a document signed. It's a process where you can be quite sure that this person has been provided all of the information they need to make a good quality decision, that they've understood it, that they've been able to sit with it for a while, that they've had the opportunity to ask you questions, and when they decide to go ahead, it's in that context. And doing a really good job of that, includes probably reflecting on some of the pointers that we always give clinicians around consenting and doing that well. Thinking about how you frame things. Is there anything you don't understand? It's a yes-no question. It's very easy for a patient to feel a bit intimidated. They're not wanting to take up your time. They say, oh, it's fine. Think about reframing that. I've given you a lot of information today. It would be helpful for me to hear your understanding about your condition, what's going on for you, and the treatment options that we've discussed. Suddenly then you're engaging a person in a discussion where you can start to get a sense of how much they've taken in. Have they really understood what you've been saying to them? So it's a funny overlap between actually what we would like consent to always look like.
That's right, yeah.
But it's in a context where you might have more time and resources to be able to achieve that standard. And I think because of the problems around the potential for conflict of interest, the issue of this being a procedure that's not necessarily indicated to improve someone's physical well-being, the council will hold you to that higher standard.
It's interesting looking at, just how detailed this whole statement is, and sort of thinking on the one hand, oh, this is terribly restrictive and proscriptive and all of those other things. But actually, when you think about it from a medico-legal perspective, this all makes perfect sense that if you follow these guidelines, actually you're much less likely to have complaints, and complaints are not easy things to deal with, and notifications to the medical council are not easy things to deal with. And we know that they have a significant psychological impact on the providers who are the subject of those things. And so yes, it turns it around from being something that looks like an imposition to actually being a very protective kind of set of requirements, if you like. And so from that point of view, from a medico-legal perspective, and not wanting to increase our own workload as lawyers and medico-legal advisors, we would have...
Yeah, I agree. Look, there's something quite comforting about having a statement that is reasonably logical, reasonably thorough, reasonably directive about what it's asking you to do. Not all of council's statements are like that, and do leave a lot of grey area for you to find yourself in trouble for something that wasn't necessarily clearly articulated as being verboten. And this statement is more of a roadmap to good practice, like you've described, Tim.
Oh, that's very good.
And certainly I know there have been concerns expressed that this is around patch protection and that kind of thing. But yes, while there may have been an element for some people who have lodged notifications with the Medical Council of that, putting that aside, it's still actually a logical kind of document and very protective from a medico-legal perspective.
Yeah, I think if one of our members came to us with a complaint and they had followed this statement, we'd be really happy and we'd be able to help them respond.
It would make our collective jobs and Adam's job much easier.
That's
exactly.
right.
Yep.
That's right. And so going along with, continuing on with consent, they say that that consent is the responsibility of the treating doctor, and that goes along with financial consent. So we get lots and lots of complaints from patients that they were overcharged or they didn't know how much things were going to cost and they were expecting X outcome. And they were charged for complications. And I think financial consent is an important part of providing cosmetic procedures because of that conflict of interest and because you're doing it for commercial purposes. So always useful to be very clear and upfront about your fees and cost, and always best done in writing.
Yeah, it's interesting, Chow Yen, to reflect on the fact that in New Zealand, there aren't actually many instances where you will go to see a doctor and for it to be this transactional, or to expect to be given a price list for a procedure. Most people will be accessing care publicly, and yes, they pay the GP's fee, but it's a fixed amount. Or they'll be going forward for procedures that are covered by some sort of health insurance, getting their knees and shoulders repaired later in life. For a relatively young person to come forward for a procedure where there's a dollar sign and a certain amount of money, it's not a common thing in New Zealand. People aren't used to it. And when perhaps not being used to the financial side of medicine, when you go forward and you agree to have a procedure and it either costs a lot more than what you were expecting and the financial consent hasn't been done well, or the outcome you wanted isn't produced, but you've invested a lot of money in achieving that outcome, it's hardly surprising that this generates so many complaints.
Yeah.
Yeah, and certainly, when you are paying a significant amount of money, because these procedures always involve a significant amount, it is actually reasonable for a patient to have reasonably high expectations. And those expectations may be slightly higher in this circumstance than, as you say, going through the public hospital system and having a procedure which is necessary and urgent. It raises the bar higher, I think, in terms of what is a reasonable expectation on the part of the patient.
That's right. And so as a bit of an aside, when you go to advertise your services, council also states that you've got to give realistic expectations and don't overstate your qualifications and don't overstate what you're going to achieve.
and the whole council statement on advertising, of course, that covers this. But one of the particular things, for example, for cosmetic surgery would be, the use of before and after photos.
Yes.
And they've often been criticised by the council as being, giving unrealistic expectations of what might be able to be achieved.
Yeah. And so the rest of the statement does follow on and provide what should be really standard care, and it's really good care. So it talks about that, as part of the whole informed consent process and giving the patient information about their procedure, you give them that information about how long recovery times and requirements are. You talk about that if they're dissatisfied, that they can complain and who they can complain to. You talk to them about who they could call after surgery if they've got concerns, and who they can contact if you're not available. And then the usual range of post-operative symptoms, unusual symptoms, and give them specific dates for follow-up visits. So it's very, very specific and detailed when it comes to that aspect of providing care.
There's also a specific comment about being very careful if you're considering a cosmetic procedure on a minor.
Absolutely.
And I think most clinicians would feel pretty uncomfortable about doing that. Yeah.
So one of the final things in the statement was, as Charles Eunice said, a lot of it is really drawing from other statements the council has and amalgamating them together as a roadmap for best practice care in relation to cosmetic procedures. And perhaps it would be fair to say raising the bar slightly for procedures of this type. To say, if you're going to be doing procedures where there is that question around both potential conflicts and whether a procedure is indicated, then we will expect the best of you. We will expect the best of you in terms of consenting, information, good quality care, and then finally at the end, the statement provides that if you perform cosmetic procedures, you must participate in clinical audit or reporting on a number of clinical indicators. Ideally, this should occur annually and should contribute towards mandatory requirements for CPD and recertification. And I'm guessing, and Tim and Chow-Yen might know for sure, that a lot of the accreditation things will probably have a auditing type framework built in with them. But if they don't, then you need to be reminded of that specific expectation which attaches to cosmetic procedures.
Yep, not aware of the fine details, but yes, you'd have to assume that was the case.
Yeah, I think if there was a complaint and they were querying your qualifications or they had concerns about how you provide care, they'd be asking you to produce that audit and asking you what your patient satisfaction outcomes measures are and whether you've ever measured them before. And it would be reassuring if you have.
Yeah.
One of the things that this kind of brings up with all of these, cautions is that I remember talking to a very wise surgeon some years ago, and he said that the real skill of the surgeon is not the practical bits, but actually the finest skill is in deciding when not to operate.
That's right, yeah.
And that's partly where this conflict of interest comes in, isn't it? Because if your remuneration is dependent on doing surgery rather than just talking to someone about saying, I'm not going to do your surgery, then that needs to be taken into account. And it's really important that doctors doing these procedures don't allow their bank balance to override their clinical judgment.
Yeah. Because I think it's a really significant conflict of interest when your livelihood depends on it. And also because of that, complaints can, like we were talking about before, come from all sorts of avenues, sometimes unexpected. Colleagues can complain because of professional rivalry. So they're all things to take into account when you are practicing cosmetic procedures. So we've come to the...
Just a brief comment before we come to the end.
Before we come to the end, comment from Tim.
Is around qualifications, because we didn't go into a lot of detail about that, but the Medical Council has a very specific list of qualifications that you're allowed to use in the New Zealand setting. And so there are many doctors who have trained overseas for procedures,
Yes.
may have a certificate or whatever from an overseas institution, but unless it's on the New Zealand list approved by the Medical Council, you're not actually able to use that qualification as part of your designation, if you like. So in advertising, you're not allowed to use that qualification, etc. So you may have the skills, and you will still need the accreditation within New Zealand to do those procedures.
And that's if someone's going into this for the first time, either choosing to take on a supervisor role with someone providing cosmetic procedures or setting up the practice, there are some good front-end pause, think, get some advice moments, I think, around any advertising that you're going to be putting out. That's something that you may find helpful to get some advice about to make sure that you are not breaching the council's expectations. Get some advice around your qualifications. Make sure that the procedures you plan on doing are all ones covered by the qualifications you have, that you're permitted to do them. And then get some advice either from the college or whoever's you're connected with around CPD for setting up that auditing, and perhaps also setting up the front-end systems that you're going to adopt for consenting. All of these things done in advance will put you in the best possible place for running a practice that's going to be safe from a medico-legal perspective, and you'll know in advance that you're complying with the statement rather than getting your first complaint or notification, reading this for the first time and thinking,
Oh, no.
how do I fit my round peg into this square hole to prove that I've been doing an okay job?
Because most of the time you have been doing an okay job.
Yeah. Yep.
Okay. Some other comments?
No more comments, from me.
No, I think that's it from me too.
Oh, wow. Thank you both so much. Just a reminder that each case will turn on its own facts. So if you have any specific queries, please feel free to contact us on our 800 number to discuss. And then that brings us to the end of our podcast. So thank you for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.